Okay, welcome back. Let's talk about the different phases of burn injury. Let's go back to our PowerPoint. Let's talk about the different phases. So the first phase of burn care is the emergent phase. With these phases, they're going to help determine what treatment we do as to which stage of injury it is. So the emergent is our first phase. It starts with the onset of injury, so when that burn injury occurred, and it ends with the completion of our IV fluid resuscitation, so typically 24 hours. So the emergent phase lasts from the time of injury till we're done with our fluid resuscitation, which is 24 hours. With the emergent phase, our goal is fluid resuscitation. Priorities during this phase are our primary survey, so A, B, C, D, E. We'll talk about that here in a second. Prevent shock and prevent respiratory distress. Also with that emergent phase, we're going to worry about other injuries, so broken bones, C-spine injuries. We're going to do the initial wound assessment and initial wound care. The acute phase is our middle or next phase. So it begins with diuresis. So after the emergent phase, usually 24, 36 hours after, but it begins with the diuresis. So all that fluid re-immobilizing. And then it ends with major wound closure. So not all the wounds have to be healed, but the major ones have to be closed and healed. The goal during that stage is to prevent sepsis. Priorities are wound care and wound closure during the acute phase, prevent and treat complications such as infection or pneumonia or acute kidney injury, and then nutritional support. So remember, the goal is, or acute phase ends with the major wound closure, we need nutrition. So nutrition is big in this acute phase. Our last phase is the rehabilitation phase. So this typically, they say, begins with the major wound closure and ends with the client returning back to their optimum level of functioning. So it may not be their baseline, how they were pre-burn injury, but what they can do now post-burn injury. And I say this begins with the wound closure, but in reality, the rehabilitation phase starts as soon as they come into the facility. So the goal with the rehabilitation phase is to prevent contractures. So remember, contractures are those shortening of those muscle fibers, limits our range of motion. So we want to prevent that in this stage. So PT, OT, speech therapy, recreational therapy, all going to be involved. You may also see priorities for functional or cosmetic reconstruction in this phase. Maybe some counseling related to the trauma. So now let's talk about the emergent phase. So we said the emergent phase starts from the onset of injury to the completion of fluid resuscitation, so typically 24 hours. The goal here is to give fluids, perform fluid resuscitation. So first, during the emergent phase, we want to remove the client from the injury, from the source, stop that burning process. But remember, make sure the scene is safe. You don't want to become a victim either. So assess the scene. If you can, have the client walk out to you. So if it's fumes or something they're exposed to in a small enclosed space, or if it's a thermal with a lot of smoke and fire, have them come out to you. Don't become a victim too. So remove all their clothing and jewelry. Clothing can help smolder the fire, or hold the fire in, hold the heat in. Take the clothing off, take jewelry. Also, jewelry and clothing can be like a tourniquet when the edema happens. So you want to get it off before edema happens. Also, stop the burning process. Run cool water over the burn. So if it is a thermal burn, we want to run cool water to stop that burning process. Just cool water. You don't want to do ice water, submerge it in ice water. That can actually damage tissue. So just cool water for 10 to 20 minutes. over that burned area. Now, if it's a chemical burn, you want to run copious amounts of water, lots and lots of water, to help flush that chemical from the skin. While we're cooling down that skin, we don't want it so cool that it's colder than the non-burned skin. You want to just cool it down to the temperature of non-burned skin. If our client has contacts in, we need to remove those contacts from the eyes. One, if it's a chemical burn, it might trap the chemical in. Two, if it's a thermal burn, it may trap heat or smoke or any other little particles in the eye. Also, during this emergent phase, we need to establish the time that the burn occurred, so what time the injury actually occurred, and calculate our TBSA. Once we get our TBSA and the time the injury occurred, then we can start calculating our fluid resuscitation needs. We also want to make any referrals to the burn center during this time. So during the emergent phase, there are a number of complications that can happen. One is airway. So remember, we talked about inhalation injury, so be suspect for that. Increase our head of bed if we're not worried about a C-spine injury. Help facilitate breathing, help facilitate drainage, venous return. Monitor our O2 sat. So remember, if we're worried about carbon monoxide poisoning, take that O2 sat with a grain of salt. Probably going to do an ABG with a carboxyhemoglobin level, so look and see if they have carbon monoxide poisoning. And remember, a normal CO level is less than 10. We're going to give them humidified O2. So humidification helps decrease that inflammation, helps facilitate the sloughing off of those tissues so that they can breathe. Intubate if necessary. Encourage deep cough deep breathing, maybe an incentive, maybe a flutter valve. We might need to suction them if we're worried about them inhaling contents or smoke, get that soot and chemical particles out. We may give them bronchodilators, help open up those bronchi, because remember, they had bronchoconstriction, so we need to do bronchodilators, open them up so that they can breathe. We may even give them mucolytics, help get that stuff out, thin up those secretions, get those particles out. Fluid, we talked about their risk for burn shock or hypovolemic shock because those vessels, capillaries, are becoming leaky and leaking fluid out. So we need to give fluids. So we need to get 2 large bore IVs. Why 2? Well, what if one goes bad? We still got one we can switch to if needed. Also, they're going to be getting tons and tons of fluids. You might actually have to give boluses through both IVs. So when we say large bore, we're talking about 18 gauge or larger. With peds, anything you can get, we'll take. So whatever size you can get for a pediatric patient. If you can't get IV access, there's always IO, so intraosseous, and we can give fluids that way. Once they get to a facility, they may keep those peripherals or IO, but they may also start a multi-lumen or central line. You can place IVs in burned skin, but it's preferred to try the intact skin first. But if a lot of it's burned, you can put an IV in through burned skin. We want a central line, preferred one, so that we can give multiple things at one time, because, you know, multi-lumen or central line has multiple lumens. So we can give stuff at the same time because those go through different parts of that line. We can also assess a CVP with a central line. Also watch for any fluid shifts. So remember, we're worried about compartment syndrome, especially with circumferential burns. Watch the airway with the edema. So elimination. They may have impaired elimination because those kidneys are not working because A, they're not getting perfused. Maybe there's a lot of myoglobin stopping them up. But either way, we need to monitor accurate I&O. So we'll put in an indwelling urinary cath. So our urine output is the most accurate indicator of fluid volume resuscitation. So if we're not perfusing the kidneys, we're not perfusing anything else, right? So if the kidneys are working and putting out urine, then we're perfusing everything. Also, we say that urine output is more accurate in the burn patient because these patients may be hypermetabolic at some point. So their heart rate may be elevated, blood pressure might be slightly elevated. So those may not be indicators of fluid resuscitation because they still may be elevated even after we adequately resuscitate them. At the burn center, for the urine output counters, they have these special machines that actually track and count your hourly urine output. They're really neat. So, and it's displayed on a big screen. So when you walk by that room, you can see 30, 50 mLs per hour, whatever it was last hour. So if it's low, you know right away that it's low. With elimination or GI, so they may have hypoactive bowel sounds during this phase. Remember, they're in shock. Things are shunting away. We need to decompress that stomach, put an NG tube down, hook it up to low intermittent wall suction. H2 blockers, PPIs, prevent that Curling's ulcer. Pain and pain management is big during this emergent phase, especially with those partial thickness burns. Those nerve endings are exposed, so they're going to be in a lot of pain. Remember, full thickness won't have pain, but the surrounding tissue that's not full thickness may feel pain. So what are we going to give them for pain? Let's give them some opioids for pain. We're going to give it IV, not IM, because remember, they're vasoconstricting, so the IM may not be uptaked. Also, think about their skin. We don't want to compromise their skin any further, and there may not be a site to give it if all their skin is burned. So give it IV. Hypothermia. So in this emergent phase, they're at risk for hypothermia. Remember, those burn wounds act like windows. All the heat goes out. So monitor their temp. Cover your burn wounds. Cover them with a clean sheet. Maybe a warm blanket if you have it. Also, the covering of the burn wound helps with that breeze pain that they may have. We might give, when we do our fluid resuscitations, we might give LR warmed. So warm your IV fluids. If we're transferring a client to the burn center, don't worry about dressing the wounds. Just get them out of that burn source, cool it, and then loosely cover it with a gauze and then cover them with a sheet and blanket. Once they get to the burn center, they're going to need to expose those wounds and assess them anyways. So don't worry or waste time on doing the burn wound care. Also, just a side note, home remedies. There's a lot of home remedies for burns. I've heard butter, I've heard vinegar, I've heard oil. All of these things actually trap the heat in and further worsen the burn. So no home remedies. So remember, cover them, hypothermia. With the hypothermia, it may cause vasoconstriction. And if they're vasoconstricted, that's further going to worsen their tissue injury, even if we give them fluids. During this phase, if it is an electrical burn, we may do a 12-lead ECG and then put them on continuous telemetry monitoring. Also, during this phase, they may need a tetanus vaccine. So try to determine when the last time they had their tetanus vaccine. If it's within the last 10 years, they may or may not get another one. But with tetanus, we're worried about the infection from, a lot of times it's in the soil that they get the infection. So give them the tetanus vaccine, help prevent that. During the emergent phase, we need to complete our primary survey. So A, B, C, D, E. A is for airway. So airway maintenance. With respect to C-spine, we're not assessing the C-spine here, but if we expect or suspect a C-spine injury, we need to be careful when we're maintaining or establishing an airway. If we're worried about carbon monoxide poisoning, 100% O2 via non-rebreather, get them out into fresh air, out of the environment, the burn environment. Gas exchange, we need to be mindful of their gas exchange. Establish an airway if they need it. So if we notice signs of inhalation injury or signs of respiratory distress, we may need to intubate them. And remember, specially trained nurses can intubate, but you have to be trained. B is for breathing and ventilation. So give them breaths, see if they're breathing, assess for bilateral chest rise. So maybe the fire is related to trauma, and now they have a tension pneumothorax. So only one side of their chest is rising. So assess for that. Assess the depth of their breathing if they are breathing on their own. Are they taking deep enough breaths to adequately ventilate? C is our circulation or cardiac status. So look at their blood pressure, look at their map, look at their heart rate, look at their skin color. So the color of the non-burned skin. Are they pale? Are they, do they have erythema? Look at their O2 sat. Again, if we're worried about carbon monoxide poisoning, the O2 sat may not be accurate. Look at their cardiac rhythm. Are they in a lethal dysrhythmia like VFib or asystole? With the circulation, we're going to give IV fluids, so insert 2 large bore IVs. In this stage, we're just worried about starting IV fluids. During our secondary survey, that's when we'll do our TBSA calculation, or TBSA and fluid calculation. So here we're just going to get some fluids going while we continue to assess them. So D is for disability, neurodeficit, or gross deformity. So look for disability. Do they have a femur fracture from where they fell? Is their leg turned inward or outward, or just a malposition you know is not normal? Also look at the C-spine. Are they at risk for C-spine injury? If so, we need to immobilize it. Also think about your GCS during this stage, your Glasgow Coma Scale. Assess it. Remember, a GCS less than 8, intubate. So then E is our expose and examine. It's also environmental control. So remove the clothing and jewelry. If we're worried about a blast injury or electrical burns or broken bones, immobilize them, get them out of that environment. Also, maintain a warm environment, because remember, they're at risk for hypothermia. So give them a coat if you have one, a blanket, a warm blanket, a sheet. Cover them, cover those burn wounds. So with our primary survey, we're going to go in that order. So A, B, C, D, E. A first, E last. So after our primary survey comes our secondary survey. So with the secondary survey, we're going to do a history, their past medical history, past surgical history. We're going to do our head-to-toe total body assessment. Here we're going to do our fluid resuscitation calculation and administration. We may even need to provide some psychological support for the patient if they're involved in a trauma or going into shock. We want to obtain a good, thorough history about the burn. So how long were they exposed? What was the source? Was it in an enclosed space? Any other prior treatment, maybe treatment they had at the scene, maybe treatment en route. If they have any pre-existing medical conditions, because we're kind of thinking about referral to the burn center here. With our secondary survey, you can remember the acronym AMPLE. So A is for allergies. Do they have any allergies? M, medications. What medications are they taking? Maybe prescribed to them or not prescribed. Any illicit drug use, because remember we said with burns, drug and alcohol use is big. P is for pain and location. Where is their pain? Is it related to the burn injury? Is it related to other trauma like a broken bone, or maybe even chest pain? Maybe they're having a heart attack because of the lack of oxygen. L is our last meal. So when was the last time they ate? It's important to know if their stomach's full or empty, if they're at risk for aspiration. During this time, we should not give them anything to eat or drink. And think about it. So they're in that emergent phase. So blood flow is being shunted from their gut up to their core. So if they don't have good blood flow, they're not going to have good peristalsis. So things are going to slow down. They're going to be nauseous. They may vomit, especially if they have food on their belly. If they have food and they vomit, then they're at risk for aspiration and then could be aspiration pneumonia. And then E is environment. So where were they burned? What were the circumstances? Any other environmental factors? So just remember, the burn injury is usually the most obvious injury. It's the most distracting to us, but think about other concomitant injuries. Could be a musculoskeletal injury, any other trauma, or serious life-threatening injuries. During this secondary survey, you're going to draw your labs. So initial ABG with carboxyhemoglobin, maybe a CBC to look at that H&H, maybe look at the platelets, a baseline electrolyte level, BU and creatinine, so a chemistry. We may also do a blood alcohol level or a UDS, a urine drug screen. See if they have presence of illicit drugs. Maybe do a UA, rule out a urinary tract infection because we're going to put a Foley in. A chest x-ray to look at the lungs for inhalation injury. Sometimes with the chest x-ray, you're not going to see inflammatory changes initially. So it might just be used to rule out other things. But you're going to see on a chest x-ray, maybe they have a tension pneumothorax that we can treat. You're going to see that lung dropped. Maybe they have an increased cardiac silhouette because they have cardiac tamponade from trauma. With the inhalation injury, look at your other things, risk for other signs and symptoms. And then here we also need to do a baseline height and weight. We need the weight for our fluid resuscitation. So our goal is fluid resuscitation during this emergent phase because these patients are at risk for burn shock. So fluid resuscitation, remember with burn shock and our systemic response, it has to be greater than 20% TBSA because we have a systemic response at that point. If it's less than 20%, then they just have that localized response, so they don't really need fluid resuscitation. Also remember, when we're talking about TBSA, it's only the second or partial thickness and third degree or full thickness burns. With the fluid resuscitation or fluid replacement, we're going to use LR. So LR is an isotonic fluid, and it contains roughly the same amount of sodium and has the same osmolality as our plasma or blood. We can, if needed later on, give some colloids or other crystalloids or plasma if they need it, especially if we suspect trauma and they've lost blood. With fluid resuscitation, it's important to accurately calculate it because if we under resuscitate our patients with fluid, then we're going to cause worsening perfusion to the tissues and organs, may even cause MODS, multiple organ dysfunction syndrome. However, if we over resuscitate them, give them too much fluid, we might tip them the other way and cause pulmonary edema or CHF. So with the fluid resuscitation, the most commonly used formula is our Parkland formula. And the Parkland formula states 2 to 4 mLs of LR, because that's the fluid of choice, most mimics blood or plasma. So 2 to 4 mLs times our body weight in kilograms times our TBSA burned. So how much body surface area burned. So for example, we have a burn who we'll say is electrical. Our patient weighs 100 kilograms and they have 30% TBSA. So you would do 4 mLs times 100 times 30. That's your total volume. With that total volume, half of it is replaced within the first 8 hours, and the other half is in the final 16. So remember, during that first 8 hours, that's when our fluid loss peaks, right? That's when the most fluid loss happens. So that's why we want to do half of it within that first 8 hours. And then that fluid loss can continue for up to 24 hours. So there's your last 16, and we're going to give the last half. So when we're talking about fluid replacement and burn injury, it's 8 hours from the initial injury time, not the time that they arrived to the facility, the time the actual injury happened. So we have to take into account the time for them from when the injury happened to them coming to the facility and catch up from there. So for example, if their injury happened at 12 noon and they didn't arrive to the facility until 1300, well, that first 8 hours starts at 12 noon. So you're going to have to replace that half of fluid resuscitation within 7 hours now, because you lost that hour for transport time for them to come to the facility. So with the Parkland formula, you may see a wide variety, may use 2, may use 3 ml or 4 ml. I know the burn center just uses 3 ml across the board. For our purposes, let's, for the Parkland formula, 2 mLs for thermal and chemical burns. And for electrical burns, we're going to do 4 ml formula. So electrical, you wanted a higher ml because of that iceberg phenomena. You don't know what's happening underneath the tissues. So how do we know fluid resuscitation has been effective? Remember, go back to urine output. So a good urine output, 0.5 mLs per kilogram per hour for thermal chemical burns, or 30 to 50 mLs per hour. And then for electrical burns, at least 1 ml per kilogram per hour, or 75 to 100 mLs per hour. We want it higher, 1, because we're giving more fluid resuscitation, and 2, we're worried about that myoglobin in the kidneys again. Also look at their blood pressure. Is their systolic blood pressure greater than 90? Ideally, we'd like it greater than 100, but 90 is kind of our minimum. Are they less tachycardic? Remember, they still might be some tachycardic, but maybe they were 120, now they're 110 or 105. So also the heart rate and systolic blood pressure, remember, they might be hard to determine our fluid resuscitation because A, they're in shock, and B, they might be hypermetabolic in that later stage. In regards to blood pressure monitoring, we can put a blood pressure cuff over burned skin. Just make sure you put some sort of barrier, like a clean washcloth or a sterile towel, something to create a barrier so that that blood pressure cuff doesn't damage even more tissue. Ultimately, once they get to a burn center or the facility, we're going to put in an A-line so we can invasively monitor those blood pressures, invasively and accurately. Another way that we know fluid resuscitation has been effective, we talked about our urine output, so the amount, but also look at the color, especially when we talk about the rhabdomyolysis with electrical burns. Is it less burgundy? Is it starting to clear up some? Is there less sediment? So let's do an example. So we have a 24-year-old male. Remember, males are 2 times more likely to be exposed to burn injury. But we have a 24-year-old male admitted to the ED at 0700. The burn injury occurred at 0500. So 2 hours we've missed there, so we're going to have to catch them up. The client is assessed with deep partial thickness burns to the anterior and posterior trunk. So the whole anterior trunk and whole posterior trunk, the anterior right arm, the groin, and the anterior right lower extremity due to an electrical fire. The client weighs 176 pounds or 80 kilos and is to receive the Parkland formula of 4 mLs with LR. So you got to remember that. If it's thermal or chemical, use the 2 ml formula. If it's electrical, use the 4 ml. So let's calculate the mLs per hour for the first 8 hours. Remember to consider our time delay. So it's supposed to be 8 hours from the time of injury. So if the injury occurred at 0500 and they're not getting to our facility until 0700, we've lost 2 hours now. So now we're going to have to make up that first half in 6 hours. and then calculate the rest for the final 16 hours. So let me get the whiteboard up. Okay, so we have a client with deep partial thickness, so those count towards the TBSA, to the anterior and posterior trunk. So the anterior trunk is 18%. The posterior trunk is 18%. The anterior right arm, so just the front of the right arm, is 4.5%. The groin, which is 1%. And the anterior right lower extremity, so just the front of the right leg, which is 9%. So total TBSA is 50.5. So half of their body has been burned. It's high. Luckily, he is young. He has that on his side. So now we know our weight in kilograms was 80. If we didn't have our weight in kilograms, we just divide our pounds by 2.2, right? 80 kilos. And we're going to use the 4 ml formula. So 4 mLs times our kilos times our TBSA, which was 50.5. And leave that as a whole number. Don't change it to your percentage. So what do you get? It's going to be a very large number, so expect that. So if you get a large number, don't be alarmed. So if you times all those, you get 16,160 mLs. So that's our total, remember? So total. I'm going to switch colors. Let's do blue. So now half of that is going to go in to the first 8 hours, and then the other half is going to go over 16 hours. A lot of 16s in here. So let's divide that by 2. So divided by 2, that half is going to be 80, so 8,080 mLs first half, and then change colors again. For my second half, it'll be 80 again. So that's total for those halves. Okay, so now let's go back up to our first 8 hours. So remember, the first half has to be given over 8 hours from the time of injury. Now, in our scenario, the injury occurred at 0500 and they got to our facility at 0700. So that's 2 hours that they didn't have their fluid resuscitation that we're going to have to catch them back up on. So now, instead of 8 hours, we got to give all this volume over 6 hours, right? Because we lost the 2 hours. So 8,080 divided by 6 is equal to 1346.7 mLs per hour. So for those first 6 hours, they're going to get IV fluids at 1346.7. So think about this. How fast can you run a pump? Well, 999 is the fastest. So realistically, you're going to have 2 pumps. One running at 999 and another one running at 347.7 or 346.8, I guess, technically. So 2, that's why we need our 2 IVs. And we do have pumps available, so you're going to have to program your pump. So then the other half, after this is done, so this should be completed if they came to our facility at 0700 in 6 hours. So it should be completed at about 1300. So then at 1 o'clock or 1300, we're going to switch to our maintenance, which is the other half over the next 16 hours. So 8,080 divided by 16 is equal to 505 milliliters per hour. So after that initial 1346.7 has been infused, we're going to switch at 1 o'clock or 1300 to 505 milliliters per hour for the next 16 hours. So that's a lot, 500 mLs per hour. That's a lot. But we got to do it because we know they're going to lose fluid because 1, those vessels are exposed so they can leak their fluid, and 2, from that shock response, and those capillaries are very leaky. Okay. Let's go back to our PowerPoint. Okay, so with the emergent phase, prioritize your patient like a trauma patient, so our ABCD primary survey. Look at their pulses, evaluate their pulses, be on the alert for compartment syndrome, so your 5 or 6 Ps. Look at their rhythms, watch and trend their vital signs. We may do some hemodynamic monitoring once they get to the facility they're going to stay at. If we are taking a blood pressure and we can't hear the sounds with our stethoscope because maybe their blood pressure is so low, remember we can use a Doppler for that also. So you can use a Doppler to measure the blood pressure, also assess the pulses with a Doppler if you can't palpate them. Remember, we can take the blood pressure in an extremity that's been burned, just put some sort of barrier device like a clean washcloth or sterile towel. Also, elevate those extremities that have been burned, facilitate the venous drainage. Elevate them above the heart level. Start your 2 large bore IVs. Once we get to a facility, they're probably going to get at some sort of central line. We're going to put a urinary catheter in to monitor that output every hour. We may do a UA, look and see if it has that myoglobin in it. We may also notice that it has glucose in our urine, and that's related to that stress response. Remember, my cells are resistant to the insulin, but my body knows that I'm starving, so it kicks out glucose to help facilitate the shock process, but I can't use it because of insulin resistance, so then I'm excreting it in my urine because I have too much of it. Also, if we're worried about the rhabdomyolysis in burgundy urine, assess it, give adequate fluids, calculate our TBSA and fluid requirements. A lot of facilities have nurse-driven protocols for fluid resuscitation. This just helps facilitate the process so that nurses can start working on these protocols and don't delay treatment. Make sure you guys look at chart 62-6 in your med-surg book on page 856 or 857. So this is the care during that emergent phase. Remember, our goal is fluid resuscitation. Do your primary survey. After your primary survey, then you can start your secondary survey. In your secondary surveys, when you're going to do your TBSA and fluid calculation. Primary survey, you're just going to establish that they've been burned. You want to stabilize them, cover them, assess them for other trauma. Remember, the emergent phase starts at the time of injury and continues throughout fluid resuscitation, so usually 24 hours. After the emergent phase, we start the acute phase. So I want you now, take a break, come back, we'll talk about the acute phase.